Hi, everyone. Welcome to another episode of the Consulting Room Pod. My name is Dr. Omer. I'm a GP in Manchester, as well as the head of clinical services at Valor, that provides national support service across clinical and admin for over 100 practices nationally. And next to me, I've got Valid. Introduce
Hi guys,
yourself.
so I'm Valid Gafoor. I'm a GP partner in Manchester and I'm the CEO of Ala. And we're hoping to take you guys through some interesting topics.
Yeah. So today we thought we'll make the episode a little bit more policy focused. I know we had a couple of episodes a bit about background and stuff like that, but the GP contract would be an interesting point to start off. I know there's been some controversial takes, and it'd be interesting to just talk through on how that affects staffing, patients, and also practice management. I know you've got some your thoughts on this, so it'd be great to hear them.
Yeah, so it might be good to just set the scene a little
Yeah.
bit because contracts are obviously legal documents and most people probably don't have a massive amount of insight into what it means. So the way general practice works is there will be a contract that's issued every X number of years and it has core themes and then there's usually amendments that happen over time reflecting what they want to be addressed. So as an example, people might be surprised to learn that GPs don't have to offer blood tests and they don't have to offer ECGs. It's not in the contract. So sometimes you'll hear this phrase, it's not in the contract, meaning it's not what we're supposed to do. Most GPs offer blood tests and offer an ECG because it's weird not to. And because it's problematic for the patient to have to go to the hospital every single time they need a blood test. But if someone is doing like the bare minimum of what they need to do, then they're not going to do something that's not in the contract. And that's why the national contract is so important because it helps guide what you should be doing. And lots of things in there are mandatory. So things like, seeing children under a certain age and triaging them within the day, like these kind of things are like, contractually established. So historically, the contract has always been focused around preventative care. It's been focused around long-term management, long-term condition management. But what's really interesting is we had a guidance change in October, which wasn't really a contract change. It was like a position statement to basically say that, GPs have to have a digital access method open from 8 till 6:30. They're not allowed to close that. They have to be able to respond within 24 hours to it. So that was not a formal like new contract. It was just like a position update in terms of that's what's happening. So usually when you do mandatory position updates, you kind of have to like do something with the actual contract so that it's reflective of that. And following your contract is what you're held to. So if you're in breach of your contract, your practice can actually be like taken back by the ICB, and so you could no longer have a practice.
Does that happen often?
Not really. I mean, it happens very, very infrequently. I mean, most people are not incentivized to breach their contract, are they? So obviously, people tend to, as a minimum, do what they have to do. So in the new contract, it's very acute care focused, which most people in primary care would argue is kind of not the point.
Yeah.
That would be the argument. It's kind of not what GPs are here for, and it's important to understand why we're here. So if you look at the way care is delivered, what are we measured on? What are we rewarded for? So if you look at how GP surgeries work, they're paid for having an amount of patients. So if you have an amount of patients, it's assumed that a lot of these patients don't need anything doing. And therefore the amount of funding you receive is very, very small because most people don't have health problems or don't need your help, or maybe need secondary care help, and therefore they don't really ever come to you. If someone's got epilepsy, they're going to see a neurologist, they're not coming to you.
Yeah.
Traditionally speaking, the medication changes are done by the specialist. So the GP is being funded to obviously support and facilitate that work, but you're not routinely involved potentially. The next big funding streams are mostly tied to long-term condition management. So we have QOF, we have things like local DESs, we have locally enhanced services, and none of these are acute care focused. So if I look at the LESs that we have, the locally enhanced services, ours are around contraceptive implants, not sending them to the hospital to have an implant fitted, do it yourself. And if you do it yourself in the surgery will be paid for it. We're not talking massive amounts of money. Normally you're breaking even or making a very, very slight profit. And obviously what you don't want to do is offer a service, but actually you make a loss.
Yep.
So that's what you want to avoid. That's just bad business planning and bad business sense. And every now and then you might do it because the patients really, really benefit from it. What you then find is all of the QoF parameters are on chronic disease, managing them effectively, doing what you need to do. But this is the first time there's been almost a stipulation or mandated requirements to do something for acute care.
Why do you think that is?
Well, I think it's because of disease burden, right? So, in an ideal sense, if you look at how the country is set up with healthcare, if you have a minor illness and it's one of the 7 core minor illnesses, in a perfect world, you should be going to the pharmacy,
Hmm.
right? That's obviously what the NHS
Pharmacy
want.
first as well. Yeah.
That's why they called it pharmacy first, right? So you have an acute illness, go to the pharmacy. We know that pharmacy first is not used anywhere near as well as it should be. When I say should be, I mean from the government's perspective,
Hmm.
right? They would want it to be the default. They would want no sore throat to ever go to general practice,
Yeah.
right? I mean, why that's not happened is probably a conversation for another time, I imagine, but it's not happened anywhere near as well as they would want it to. And obviously, some areas do it far better than others, and there's learning to be had all around. So you've got all the minor illness being sent over there. You've then got recurring problems, which kind of start falling into complex care or they start falling into chronic disease. Because if you've had sinusitis and you've had it for 3 months, it's not really an acute illness.
Mm.
You're dealing with chronic sinusitis, and that probably needs to go and see a specialist. So all of that comes to general practice anyway. So then you've got the people that are really, really unwell with their symptoms. They don't go to pharmacy first. The GP doesn't send them to pharmacy first. They don't know it exists. The GP is so busy delivering this planned care, which is what we're supposed to be doing, that they don't have the capacity to deal with this acute problem. But we know that patients care about their acute problem because it's symptomatic, right? If you've got a sore throat or you can't breathe or you've got a urine infection, you're not going to say, oh, you don't have any appointments. Okay, well, I guess I'll sit at home then.
Yeah.
That's not your default, right? So either you're going to ring 111, you're going to use an out of hours service, who are normally going to want to examine you, right? And the problem is that they will half the time redirect you back towards your GP. So you're in a vicious cycle then. So you ring 111 at 9 p.m. They say, oh, your GP will see you tomorrow. How they promise you that, I don't know, because obviously they don't work in the practice.
And they don't have access to the appointment list.
Yeah, they don't know anything about how that practice works. But again, a really highly inefficient use of how we do things. The patient is now convinced that they're going to get dealt with by their practice. Practice doesn't deal with it, doesn't see them, doesn't get involved. Patient's very irritated. There's lots of these, what I call waste of time things that happen in healthcare. And then the patient gets more unwell, is very frustrated, maybe rings the practice, rings 111, same waste of time loop repeats itself.
Puts a complaint in that needs to be dealt with, and there's all this passive time.
It's just a lot of this type of stuff, right? And then half the time they end up in A&E. So A&E becomes the default because it's open door policy, isn't it?
Yeah.
So if you don't need an appointment and you're going to walk in, when in doubt, go to A&E. So that's unfortunately how the healthcare system is designed. So A&E is always clogged. It's always many, many hours of wait. So in some places, like a 1 day wait to get seen in like an A&E department. And so, but a lot of what they're dealing with is inappropriate, right? It's inappropriate. It's not an accident or an emergency. And that's why nationally, A&E got changed to ED, which is emergency department, because basically most accidents don't need anything. If you've got a little splinter, either pull it out yourself or go to an urgent treatment center, go to a minor illness unit. You don't need an emergency. It's for emergencies. That's what it should be used for. So I get the frustration. What I don't understand is how making GPs do this is good or useful. I don't understand.
Do you feel like it's just shifting some of that?
I mean, that's literally all it is, right? It's literally just shifting care, because they're trying to relieve the burden on secondary care, which I understand. What I don't understand is when the funding has been allocated to primary care networks, because we've not had substantial increases in primary care funding in the surgeries. That funding has either gone to community pharmacy or it's gone to primary care networks. Why are you now talking to the GPs about this? Talk to who you gave the funding to. Do you know what I mean? Like, as in, if, and I don't mean that to be flippant, but we know we need to do better with blood pressure. We know we need to do better with minor illness. We know we need to do better with contraception. All of these things have been funded at community pharmacy. So a community pharmacist gets paid, or the pharmacy gets paid, for every contraceptive review that they do, for every spot check of blood pressure they do, for every ambulatory blood pressure monitor, and it's significant amounts, like in excess of like £50 a go for one of these things. They get paid for every acute illness consultation that they do. So they're being paid to do it. So make the patient go there. It would be my obvious thing, right? Because these people are incentivized to do the work because they're getting paid for it. You obviously think that's the right thing to do. That's why you funded the service. If somebody came to our practice and they said to us, we would love you to take over some of the burden of A&E, I'd say, okay, great. So are you going to continue giving us the same funding for doing less chronic disease?
It's obviously not going to happen.
Is that how we're going to create the capacity to do this? Because I'm going to redeploy the staff. Oh no, just do it as it is. With who?
Yeah.
Because these people I'm using to deliver the chronic disease which I'm supposed to deliver. So do I need to now get another GP and a paramedic and a nurse practitioner to deal with the breadth? Because some of these are like medication related issues. Some of them are like a migraine's not being effectively used and a pharmacist would do it really, really well. Some of it will be I've got back pain and maybe a physiotherapist would be ideal. Like, it's not likely that one person has the broad skill set to do everything unless they're a GP. But the GPs are what are not being funded. So, if you're not going to fund me to use a GP, I'm then going to need multiple people. I'm then probably going to need a physiotherapist or a paramedic to deal with the joint problems. I'm probably going to want a pharmacist to deal with the medication issues. And if it's something like my asthma is really bad or my diabetes is really bad, I'm probably going to want a nurse.
Yeah.
Because they're the people that tend to do the chronic disease, right? So we're going to need funding. And I imagine either ICBs would have to say, we'll give you, I don't know, X amount of payment for every patient you see. Either it's going to be like that, or it's going to be a case of you have another phone line for acute care and cases come through. I don't know what it looks like. But the obvious thing to me is all these roles that are supposed to be delivering acute care are literally employed by the PCN. So why is this not just a PCN project? That's what would make sense to me. And actually, our PCN has what we call an urgent action clinic, where somebody that presents with an acute problem that doesn't fit the pharmacy first criteria goes to the PCN and they see a paramedic. And if they've got an acute joint problem, we have a first contact practitioner, which is a physiotherapist, and they go to see them. So we kind of have that.
Yeah.
That's how our PCN is structured.
And not all PCNs are like that.
Yeah, I mean, this comes down to what your PCN's priority is, right? So I think what would probably make sense is if a locality like a neighborhood had a solution like this. So, my practice is in Tameside in Hyde. And for example, if we had a neighborhood in our area, I could imagine that there'd be some funding, whether it's all the PCNs pooling their funding in, whether it's the ICB commissioning it, whether it's a separate pot of funding. I don't know. I don't know where that funding comes from. I mean, I would argue take it from the hospital. If you're going to complain about funding, take it from the hospital, right? They're the ones who now should need less people to work because we're going to take this work. Because funding it's always a funding issue. Take it from somewhere and let us deliver it. So if these are people that are relatively well and they don't need lots of x-rays and lots of blood tests, it should be cheap and effective to deliver care. So let's create a central hub, an area. Let's have the locality send the referrals in there and let's have people deliver care. So I feel like I've talked around it quite a lot. But as you can imagine, primary care is not very happy because what will happen is there will be a significant inadequacy in funding to match what is required.
So the demand will increase, it won't match it. And then we're talking about all that passive time wasting that's happening. And we often talk about the patient journey. And that patient journey you alluded to is going to be zigzagging around all these avenues that they don't quite understand. And sometimes even reception staff that are sending them don't quite understand, and causing more frustration.
It's just consistent. I'm just going to very quickly make this point because I don't want to interrupt you. It's just we don't have consistency, right? So either acute illness is not for GP surgeries to deal with, and it should go to the pharmacy. Great. Give the pharmacies more money and make them do all of it. If that's what you believe is the right thing to do.
But also there's a bit of a mismatch because, again, often these conversations are happening with the GP practices, but I don't think many GP practices speak to their neighboring pharmacies about, well, actually, what have you got available? What is there? And how can we actually communicate and effectively send that
I
across? I
mean,
know you are a big advocate
yeah,
of
I
it,
mean, we do this
but
phenomenally, right? Like
yeah,
we send 300-400 cases a month
yeah,
through to our local pharmacies to deal with acute illness because it frees up our capacity, right? It's a massive thing. But my question is, if that pharmacy wasn't playing ball with us, we would have done those 300-400 cases and we wouldn't have got paid to do them,
no, exactly.
right? So this is where the disconnect
Yeah,
is because we could have done that care, but that's 300-400 chronic disease appointments we would have then not offered.
yeah,
And then it would have, so primary care has the ability to do these things. And if you give us the funding for it, we'll do it.
mm,
And if you don't want to give us the funding for it, that's also okay. As far as I'm concerned, that's okay, right? To me, as a GP, I'm interested in preventative care. I'm not an emergency department and I'm not a pharmacy. I'm not trying to sell you anything,
yeah,
right? I'm not a pharmacy where you come in and you have an issue and now I'm going to charge you for an item. I don't make any money from it.
yeah.
So if I'm delivering acute care or chronic care, I'll deliver whatever care I need to deliver. But I'd like it to have long-term impact for the patient. And I'd like to not deliver acute care at the cost of chronic care because I'm the only one doing it.
But you can see how confusing that could be for patients.
Yeah. Because on one hand, you're telling them go to the pharmacy. On the other hand, you're saying come to us for these following things. I think either just fund acute care elsewhere,
Mm,
either fund A&E so they can deal with it all, or that's inappropriate and fund pharmacies appropriately. And if you don't want to do either of that, bring that money to us. But why are you part funding it there and part funding it here and part funding it here, and then it's not being done well anywhere?
Yeah,
If patients knew that from this date moving forward, any acute illness I need to go to the pharmacy, the GPs will say no, and A&Es will turn me away, right? If they'll do my OBS, if my OBS are stable, the A&E will make me leave,
mm,
right? Then they would know, well, I don't want to go wait 5 hours in A&E to be told to leave. I need to go to the pharmacy. And all pharmacies have to deliver it. That would be one way around it. Another one would be this pharmacy thing's not working very well. Give this funding, split it across primary care and secondary care. So A&E has more resilience and primary care has more resilience. That could work.
yeah.
But I just find the fragmented approach very difficult.
I'm being devil's advocate here, and that's only because I speak to a lot of GPs across a lot of GP practices. And one theme that comes across is quality, supervision, that element, and then also communication. So sending a patient somewhere else can be quite daunting for some GPs because there's certain ownership that patients register with us, etc. How did you combat that? And how did you approach that with your neighboring pharmacies? If there were, I don't know, complex patients that they weren't able to see, were they sent back? How did that patient react? How did you ensure that a certain level of understanding or communication around if they had any queries about certain patients? How was that dealt with? So that'd be quite interesting, I think, for our viewers.
Yeah, so the first thing is ownership
Okay.
of a patient, right? So some GPs feel like they shouldn't send their patient to the pharmacy for a consultation. And I would say that's fine, but they're being paid to do it and you're not.
Mhm.
So they want the patient. And the government thinks you should be sending the patient there, which is why they created the model.
Mm.
So if you're not doing it, you're going to do unfunded work, which is by definition going to come at the expense of something else you could have been doing. I think that's really poor business planning. I think that's really unfair on the rest of your patients who, I think that's unfair for the woman that now has to wait another 4 weeks for a smear.
Mm.
I think it's really unfair on her because there was a service that was commissioned for you to send something to, and you decided not to do it against national advice. And now your diabetic patient, a patient with diabetes, is waiting another 2 weeks. Why?
Mm.
Because you wanted to pull two people out to do acute care on that day, despite a pharmacy being fully capable of dealing with it. So I have a problem in principle
Okay.
because it's, if you're giving your opinion and you disagree with the model, give your opinion. That's fine. But the decision's been made.
Mm.
The decision's been made nationally. The funding's been set aside. What are you arguing against? That's the bit I find problematic. They're still getting paid for it. You're not getting paid for it. You've taken this unfunded work on for what? Anyway, that's probably, as you can tell, this really irritates me.
It hit a nerve there,
Yeah,
didn't
it
it?
really irritates me, right? Because the thing is, once the decision's been made, you're now disadvantaging your other patients
Mm.
by towing this line that no one's asking you to tow. So just do what you need to do and crack on. In terms of communicating to the patient and delivering safe and effective care, So we have never sent a patient to a pharmacy that we haven't spoken to in advance
Okay.
and mapped out what we were going to do. So we don't take any chances. I don't say to them, "Oh, you're with that pharmacy. I don't know how they work. Should I ask you that? Should I ask them to see you?" No, I don't know what quality of service they're going to get from
Mm.
that pharmacy. And actually, I've had a lot of bad experiences with community pharmacies where they're run by local clinicians. They're not incentivized to deal with what they call private services or what
Okay.
they call clinical services. They just want to do the checking and issuing of the prescriptions and go home,
Mm.
right? They want to do a volume based workload. Because actually, I think a lot of people don't in primary care and in general practice don't understand how community pharmacy works. So there's massive variation in how these checks are done, whether you have ACTs, whether you've got pharmacy technicians, whether you've got a pharmacist, how many items they need to get through, and how much risk there is in getting something wrong, whether there's software helping them make that decision
Mm.
or not, and how you can't do any of that if you're doing one of these cases. Because you literally have to pull a person into another room and have this conversation separately, which is not a conversation you're familiar with. It's new to you. This isn't what
Yeah.
you were originally trained to do. So you'll have had to add some additional training. You have to understand the scope of what you need to do. If it's not your pharmacy, you're not getting paid to do it. You've just taken on some higher risk clinical work for what?
Yeah.
So for you, it's almost like a bad deal. So unless you're an employed member of the workforce or there's progression scope or you've had adequate training for it, which is what some of the big chains do, you're probably not going to engage.
Mm.
And we say very, very clearly to them that the patients will not accept this if they have a bad experience. So if they come to you and you start sending them back to the practice and then they're waiting 40 minutes in the telephone queue, they're never going to accept that again, are they? If
Mm.
you were a
No.
patient and you rang the surgery and you waited 40 minutes to get through on the phone,
To be told,
to be told to go to the pharmacy, they then told you, no, we can't do anything.
go to back to your
Ring,
GP.
and are you waiting another 40
No.
minutes? Do you see what I mean? So they're never going to accept ever again in for the rest of their lives to go to the pharmacy.
Yeah.
So we tell
That bridge
them,
is burnt.
yeah,
Yeah.
and that's why we tell them very, very clearly, if you need to do something with that person, ring us. Either here's our direct line or here's our secure communication channel. Speak to us, share the assessment you've done, tell us what is required, and we will do it. So, from the patient's perspective, I've made one piece of contact, I've had my care. It was a bit odd that it happened at the pharmacy, but you know what? I got my prescription.
Yeah.
I got my prescription, I got my care. I didn't need to ring up again. If further information was required, we ring that person so that the patient doesn't feel like they've had a fragmented journey, and then they'll engage. Then they'll engage with the process and then they'll trust it works. And that's a level of investment a lot of people are probably not familiar with.
Yeah. And I think in passing, I remember when you had to practice started this, you were saying that you were spending quite a bit of time on actually getting to know the neighboring pharmacies and actually setting experience and actually being a bit more collaborative, which again, talk us through your experience with that. Was that well received? Was it not well received?
I mean, it was really well
Pharmacies?
received.
Yeah.
You know, we've had days where we've sent like 30 ambulatory blood pressure requests to a particular pharmacy. I mean, I don't want to out myself here, but if we do some quick maths on that, it's £50 an ambulatory blood pressure. So 30 of them is what?
Hmm.
So if you do 50 times 30,
Yeah, we've got on 1,500, isn't it?
yeah, so like that's in a day, in a single day.
Hmm.
And we do that 5 days a week. So it's incredibly lucrative for the pharmacy to work with us. I mean, it's doubly frustrating that as a surgery, we don't get that funding because we would have just done that in house. We've already had the patient.
Yeah.
It would have just made sense for us to do it. But this is the whole contradictory nature of it. So they're making money, they're happy to do it. The patient does get a bit confused. They'll say, I've come to you with this. Why are you now sending me there? That's how the model's set up.
Fine.
Like, you know, and patients do say, like, why can't you just do this? And I'll say, look, we're not funded to provide this service. The funding is over there. And some patients do find it really frustrating because the historic model they're familiar with is they came to the GP and everything got done at the GP.
Yeah.
And that's increasingly not the case. It's increasingly the case that I need to send you to the pharmacy, or I need to send you to the PCN, or I need to send you to this physio clinic that's not at the practice elsewhere. And they do really struggle with it. But clearly that's not what people think is important.
And just to summarize, we started this conversation off with just providing a bit of context about the GP contract and how it's pivoting a little bit more towards the acute side, which you mentioned about a fragmented model of care. Now, and we also talked about how confusing it can be for patients, for practices. For a practice right now that's facing these changes, what advice would you give them? What kind of quick wins or would you provide them that's worked in your experience?
I mean, I think I mentioned this to you once before that I think opportunistic care is the way forward, right?
Hmm.
And I think one of the reasons we struggle to deliver effective healthcare is that we just deliver healthcare badly. I think we do a lot of fragmented care. We do a lot of single disease care. We don't sometimes invest in our staff or train them. And it's not because we don't want to. Sometimes we don't know how to, or we don't have the time to. And I sometimes wish that when you have these larger bodies like ICBs, that they took some ownership of that and they sort of did stuff like, well, we've got this training grant. Can you identify someone? Let's train them in a couple of illnesses so that you're doing multi-morbidity case reviews. Because in our practice, we found that we have quite a lot of acute demand
Hmm.
and we have quite a lot of acute capacity. But the reason we have acute capacity is because, on one hand, we do our chronic disease in such a way that it's dealt with very, very quickly. We're also doing a lot of proactive work and we're treating chronic disease very aggressively.
Hmm.
So we're not waiting for them to come to us with a problem. We're booking them in for follow ups and escalating their treatments in the hope that they don't develop the complication so that they then don't need to come to us with this problem isn't fixed, this problem isn't fixed. So that's one hand. The other hand is we find when we deal with their acute care, we also take that opportunity to titrate anything else. So, dealing with acute care is dealing with someone's chest infection, right?
Yeah.
Dealing with someone's possible pneumonia. But when they come to you for their smear, or smear is actually a really bad example because of age, but let's say they come to you for their cholesterol chat. During that cholesterol chat, if they were eligible, have you given them the pneumonia vaccine, which might have then prevented them having pneumonia?
Yeah.
So it's that kind of stuff. It's like when you don't do the proactive care, you then suffer the consequence and deal with the acute illness. And we found this when I started, actually. We had a lot of patients that would come to us with very poorly controlled diabetes. But actually, over the last year, we've very aggressively started treating diabetes. We've got 4 people in the practice now that
Mm.
initiate insulin, which is for a single practice, 4 insulin initiators is a
It's
lot,
massive.
right? Like you'd be lucky in a practice to have 1 insulin initiator, and usually it's a GP. In our practice, none of them are GPs.
Mm.
So we've got a highly skilled workforce that is doing very complex pieces of work, which means that A1Cs for the patients are better controlled, which is the average blood sugar reading over a 3-month period. So the HbA1c is better controlled, which means they're less likely to develop all the complications of diabetes, right? We now don't have people coming to us with my blood sugar's 25, what do I do?
Mm.
Which used to happen when I used to do triage a year and a half ago. We used to have people putting in requests, my blood sugar's 25, what do I do?
Yeah.
My blood pressure's 200, what do I do? We don't have that anymore.
Mm.
Because when they get diagnosed with high blood pressure, first of all, we confirm it using the pharmacy, using an ambulatory monitor. So we tell them, for you, this is the way to accurately assess what's happening. We then treat them very aggressively in their blood pressure treatment. And we control, and now we don't get those things. It's so unusual for us to have a patient ring us and say, my asthma's not well controlled. My COPD is not. It's so unusual because we've gone out of our way to to address their inhaler techniques, to address their asthma COPD control when they've come in for an unrelated thing.
Mm.
I was giving you the example earlier that people were coming in for health checks, and while they were coming in for health checks, they were taking Clenil for their asthma, and I was saying to them, Clenil's against the guidelines. We should be using combination therapy, so you don't need your blue inhaler. I'd like to switch you to a different inhaler today. They were like, oh, but my asthma's fine. I was like, I'd still like to switch your inhaler.
Yeah.
And I'm going to take away your blue inhaler. It's got the carbon issues. It's got all the issues with overuse. It's a poor marker of control. We actually measure blue inhaler issuing as one of the CQC requirements for good practice. And we were just proactively switching them to low carbon footprint DPIs. So, obviously lower carbon impact. And I know doing that for our patients has meant they end up less often in A&E with an asthma flare-up. They're less likely to have an exacerbation. They're less likely to order a blue inhaler. So if you do these things, it frees up your capacity. And that's why, even though in principle I disagree with general practice doing acute care, I fundamentally disagree with
Mm.
it. It's not what we were designed to do. And I think it's different when it's a child. So I think when it's a child under the age of 12, we make an exception, right?
Yeah.
Because I think sending a child to A&E for what's very avoidable is where I draw the line. But generally, if it's acute care, we've got our PCN clinic, we've got our physio setup, we've got the pharmacy. We then do take anything else, but because we can.
Yeah.
But what if we couldn't? And this is my concern with the contract. What if a practice is not well run? What if it's not set up to free up capacity? What if they don't deliver significant opportunistic care? They just won't have the ability. Surely you would just send everything to A&E.
Which defeats the point.
Which defeats the point.
Completely.
Exactly. It completely defeats the point, right? So I think the intention is to have people do things. And I think if you're not going to fund it, because look at my PCN, right? Like, where is our physio? They're not in our practice.
No.
They're in a
The
PCN
central,
building.
yeah.
They're in a centralized model. So if my patient says I can only get to the practice, but they have a joint problem, they're not going to get seen by a physio. So how am I supposed to get them seen? Am I supposed to personally employ a physio? But the funding comes via the network.
Yeah.
Do you see how it's problematic? These broader implementation and logistics issues have not been considered.
No.
But it stops us from delivering care. So what we've ended up doing is we've ended up personally hiring a paramedic who can assess someone's joints when they can only come into the practice. That's unfunded. And we've had to do things like that. How many people would do that?
And not many.
And a lot of practices will say, well, this is unfunded work. You're either gonna have to make your way there or go to any.
Yeah.
And that's the issue. That's the risk you run, right? You run the risk of people, because people are being burnt and they're being stretched, they're losing their goodwill. So there was a time where every practice offered ECG and blood tests because there was goodwill. But when patients are being told that GPs are lazy, which is kind of like when you look at the news, when you look at what the contract says,
That's the narrative out there, isn't it?
literally the narrative every week is GPs are lazy, primary care is lazy, they don't want to see patients, and you get it in the neck from patients when they walk in. So the patients aren't on your side, the media is not on your side, and everything's about helping A&E, not helping primary care, and all the funding's going into PCNs and pharmacies. I'm not surprised that GPs are not playing ball. I'm not surprised that there's industrial action, and I'm not surprised that they're arguing with everything that's happening. But if you placed some of that funding where it is, like it used to be when the things were being done,
Things can change.
we'd probably have a better scenario, I would imagine.
So, Walid, thank you for giving us obviously quite clear opinions around the GP contract that's out there at the moment, kind of the difficulties and fragmented care that unfortunately our patients are struggling with. Now, flipping it around, let's say you were in control of everything. What would your ideal GP contract look like, or what would it address?
I think an ideal care model, obviously I'm biased because I have the secondary care hat on as well. It's kind of like what we've done with the health checks
Okay.
this week just gone, where I would want to make use of software to stratify patient data and almost help plan and control some of the care that's delivered. So it's less in the moment, because what happens is you get massive variation in the care that's delivered. So I think having a standardized approach to delivering care, and what I would like is the support structures that we should have available to facilitate the training, the infrastructure, the communication, how to organize this on a system level so that it's less variable and it's more scalable. So I think things like that would be massively helpful. If we then were moving towards a more opportunistic model where when somebody comes in for an acute problem, you're dealing with the chronic. When they're coming in for a chronic issue, you're dealing with the acute concern. Being less binary and prescriptive and being more holistic is the way forward. And I think if we were delivering more holistic, opportunistic care, one, the conditions would be better treated, and two, you'd have less anxiety around acute care, because a lot of the anxiety is around the fear of not being able to receive the care.
Yeah.
And that makes people panic. And they'll say stuff like, well, if I didn't come today, when would I get seen?
Yeah.
So I think if you were able to give people that reassurance and peace of mind, they would not panic and they would feel more in control. I think that's probably the cornerstone of how I see good care being delivered.
Okay. No, thank you for that, Valid. Um, just to summarize, we talked about the GP contract. We talked about also your ideal contract and some of your frustrations that you experienced, but also some of the solutions that you found at your practice, which has been really helpful. And hopefully the audience found that helpful as well. What is really good, and kind of talking back about how practices work often in silos, and what one of the reasons why we're even doing this podcast is sharing some of the information, sharing some of the good practice or even solutions that we found. And we would love to hear from the audience around any comments that they may have, and also if they could like this, just because it would help us share this pod a little bit more, but also using the comment sections about sharing some of the helpful advice that some of the GP partners or management have had. So looking forward to reading them, and hopefully see you soon.